Welcome to the session on diabetes and obesity, the two major pandemics that I think we face in the United States, and I'm calling them pandemics because it's a global issue. I think we have a fabulous panel today, beginning on my left with, actually I don't have your name down. It's Josh.
You got to remember it.
I know, exactly. That's Joshua Riff, who's CEO, of Ondo. Next is Mark Hyman, who's the medical director of the Center for Functional Medicine at the Cleveland Clinic. To my right is Kelly Close, who's the founder and chair of the Diatribe Foundation and president of Close Concerns. And next to her is Sean Duffy, who is CEO and co-founder of Omata Health. And finally, Hugh Waters, director of Health Economics Research, Milken Institute. And Hugh, we're going to start with you to see some data.
Great, thank you. Yeah, so I have the pleasure of giving all the bad news at the very beginning, and then the rest of the panel will then give you the solutions to these problems. So I'm going to give a very quick overview of some of the economic impacts first starting with the chronic disease burden in the US, and then looking specifically at obesity and diabetes in terms of the epidemiologic and economic outcomes associated with those two. So I'll go ahead and bring up a slide. Let's see. Okay, first slide. So we've done at the Milken Institute a very detailed study on the cost of chronic diseases in the U.S. using a wide variety of sources of data from Center for Disease Control, from American Heart Association, from a number of other professional organizations, but using very detailed and reputable sources on both prevalence of these diseases and also the costs of these diseases. So categorizing chronic diseases broadly and into these categories, we calculated that the direct costs, and when we say as health economists, we say direct costs, we mean the costs actually of health care delivery, what patients pay, what insurance pays, and what employers pay for the health care itself. So that's what we call direct costs. And as you can see, if we group chronic diseases into large categories, the total is 1.1 trillion, about 5.8% of our GDPs. And you may know that healthcare spending in this country is a little bit over almost 19%. So a significant portion of the US healthcare spending in this country goes directly to pay for treatment of chronic disease. If we go to the next slide, if we combine the direct healthcare costs, the treatment of the diseases in the healthcare system, if we combine that with productivity losses, what health economists call indirect costs, so these include lost productivity, lost work time, the effects of the chronic diseases in terms of the total economic outcomes, we can see that the costs are much higher. So some of these chronic diseases lead to a lot of obviously disability, of reduced productivity in the workplace. So the total costs, calculating using indirect and direct costs together, are almost 20% of our economy, 19.6% of GDP, $3.4 trillion. And you can see, looking at the categories, you can see that diabetes is a significant chunk, well over almost $500 billion, over $500 billion. Cardiovascular conditions in general, all by themselves, more than $1 trillion in the US. So we're going to be talking today about obesity and diabetes, which really underline a lot of these things, which I'll just get to here in a second. If I can, is that okay? I'm not, okay. Here we go. Sorry about this. Cost of diabetes, if we look at it as a subsection of these costs, total treatment costs, direct health care in terms of, again, hospital visits, healthcare visits, about 190 billion in the US, and including the productivity costs. This is the difference between the direct healthcare treatment and the indirect productivity losses. If we include the indirect productivity losses, almost $500 billion can be attributed to diabetes, the diabetes epidemic in the US. So it's a significant chunk of change. Okay. And then, of course, obesity and being overweight. This is the study that we have done. It's very detailed, looking at each of the specific diseases, the spending on those diseases, and then looking at the portion of the spending that can be considered attributable to obesity. So the way we do that is it's a mix of epidemiology and economics. to really calculate correctly the attributable risk in the epidemiologic sense that's due to obesity, you need to know two things. You need to know the prevalence of obesity, and you need to know the relative risk. Relative risk is how much more likely is a person who has obesity to get that condition, whether it's diabetes or cardiovascular disease, than a person who does not have that condition. So keeping everything else equal level, how much more likely is the person who has obesity to have the healthcare condition in question? So that's a relative risk. And so the relative risks are kind of stunning. So it makes you think a little bit about your diet, perhaps. So if you have obesity in the US, you are 3.4 times more likely to have diabetes, holding everything else constant. If you have obesity, you're over 2 times more likely to get Alzheimer's disease or vascular dementia. So if you take those numbers and then congestive heart failure, 1.3 times more likely. Coronary heart disease, 1.6 times more likely. If you take those numbers, trying to go backwards. Okay. If we take those numbers and go back here, okay, so you can see, so of these conditions, all right, so obesity, twice as likely to have Alzheimer's and vascular dementia if you have obesity. So in other words, a significant contributor to the light blue pie. Diabetes, 3.4 times more likely to have diabetes if you have obesity, the big blue slice of the pie. And cardiovascular conditions varies depending on the condition, but also significantly more likely if you have obesity compared to having a healthy weight. That's the concept of relative risk. So using the relative risk and using the prevalence of obesity, we can calculate in gory detail what is the total contribution of obesity. So the total cost of diseases due to obesity, this is an update of a report we did a couple years ago. Now it's updated with the most recent data. So first of all, almost 40% of US adults have obesity using data from the Centers for Disease Control. Total costs, 419 in direct healthcare costs, 419 billion. 1.15 trillion in the indirect costs, lost productivity, lost work time. Total $1.57 trillion, a lot of zeros on that. 8.5% of US GDP, and 47% of the cost of chronic diseases. So if we're interested, there's other contributors to the chronic disease burden, smoking, alcohol abuse, when we've actually teased out the relative contributions of those as well. But obesity and overweight are by far the single biggest contributor to the chronic disease burden. So I guess that's maybe a good way to turn it over to the rest of the panel.
Yeah, in my eagerness to get into this panel, I forgot to introduce myself. I'm Bill Dietz. I'm the chair of the Sumner M. Redstone Global Center for Prevention and Wellness at George Washington University. And prior to coming here, I was the director of the Division of Nutrition, Physical Activity, and Obesity at the Centers for Disease Control and Prevention. So I wanted to start with a human dimension on the costs which Hugh outlined, because I think that although the costs are important, the human side is equally so. There are 30 million adults affected by diabetes, an additional 84 million are pre-diabetic. 93 million adults have obesity. And it's a major risk factor for diabetes and prediabetes. So these data raise several critical questions. How do we care for those affected with diabetes, and how do we prevent progression to diabetes of those with prediabetes and obesity? One of the things which Hugh didn't mention is that these diseases, obesity and diabetes, particularly affect underserved populations. There's a higher prevalence among Mexican Americans and among African Americans, and there is an increased prevalence among those in poverty. So the first question for this panel and, that I want to pose, and we'll take comments on it, are the demands, referrals, and capacity all appear to be barriers to treatment for diabetes and obesity. So how do we overcome them? And starting with Kelly, I think an important piece of this is communication. Are people aware of this, and what kind of steps that they can take to either prevent or treat their diabetes?
Yeah, thank you so much, and for having this panel. What an honor to be here with so many of you. And so I work with a lot of patients. We send diatribe.org out. That's a newsletter that goes out about every week to about 200,000 people. And people always say to me, that's grown a lot, you know, since 5,000, 5 years ago. And it's like, actually, I mean, it ideally would be going out to many, many more. I think if people have diabetes, they don't necessarily want to sit around and read about it. And if they're at risk of it, as you say, you know, they are probably at lower socioeconomic levels. They are struggling. Maybe they have 3 jobs. Maybe they have, you know, many other things in their lives. And they don't necessarily know that it's addressable, right? So I think as a society, it's not just really even 30 million or 84 million people. It's 330 million people in the U.S. alone who we would love to have working toward health citizenship, you know? I think that there are a lot of different things that could happen if the awareness was more at the educational level and really a multi-stakeholder approach, a lot of which we see here at the Milken conference. But I think it's just very important to have cultural shifts. We heard, you know, and maybe we could just pull up slide 8. We could just look at this really, just really quickly. Some of these factors are non-modifiable, but some of them are modifiable. And this is from Alan Moses, former chief global medical officer at Novo Nordisk. But many of these things could be addressed, and I can talk about that more as we go on. But I think people with diabetes feeling that they have a menu of options, it needs to be fuller, it needs to be more directed. And we really need to feel as patients that we're being invested in. It's not a cost.
Great. Mark, you've really been in the trenches of treatment. I did a back of the envelope calculation a while ago suggesting that for every primary care provider in the United States, there are 90 patients with severe obesity, BMI greater than or equal to 40. So how do you build that capacity in the work that you're doing, and how would you suggest we expand that in terms of training and meeting these needs?
Well, I think the problem is we're focused on the wrong end of the stick in treating diabetes, because it's something that we're focused on treating with medications or medical care in hospitals and clinics, and the problem isn't there. The problem is upstream, which is our food system and the social environments in which people live and the poverty and so forth. And those have to be addressed, and if you don't address that, you're not going to be able to solve this epidemic. It's not more and better medication, which everybody's seeking, and one endocrinologist at Cleveland Clinic told me that their insulin went up like 300% recently, some of the doses they use are things. And I think that we have to really focus on creating system solutions to the problem. And that involves asking really 2 questions. What are the drivers that we can modify? What is the biology of the disease and the cause? And it's predominantly, food and particularly carbohydrates. There was a paper published in Cell last week called about carbotoxicity and its effect on insulin resistance and the progression of diabetes. And I think that the second thing is how do people change their behavior and environment? I think that has to be done through more a social solution, what I call a social cure. It isn't in the hospital. It's democratized, decentralized care that's in the community. And I've been involved in a number of efforts to test that. One is with Rick Warren at Saddleback Church, where we created something called the Daniel Plan, which is a faith-based wellness program with the operating system being functional medicine and a diet that's low glycemic, anti-inflammatory, high in fiber, lots of good fats, and doing it in peer-supported groups that allowed people to get the support, accountability, feedback that they needed to change behavior. And we thought a few people would sign up, but 15,000 people signed up the first day. It was the biggest event they ever had. They turned away 2,000 people. We ended up having the group lost 250,000 pounds in the first year, but also all the diseases went away as a side effect of creating health. So we focus on treating disease. We should be focused on creating health and doing it in communities that matter. We now have launched that in 28 churches in Cleveland and poor communities, and it's very successful. So I think we need to sort of rethink the delivery model and also the type of care we're doing. We had a patient in one of our shared medical appointments, which is sort of a secular, Daniel Plan group model. And we do these groups called Functioning for Life, and one of them's on diabetes. And we had a patient recently who had a hemoglobin A1C of 11, which for those of you who are not in the medical field, is extremely high, poorly controlled diabetes. She had heart failure, she had kidney failure, she had not on dialysis, but renal insufficiency. She had fatty liver, hypertensive on a pile of meds. In 3 days, she was off insulin. In 3 months, her heart failure reversed, her kidney failure reversed, her liver problems reversed. She was off all her medications, and her A1C was 5.4. And she lost 43 pounds, and it was a side effect of just lifestyle education. It was a 20-hour, 2 hours a week program for 10 weeks, supported by a coach, nutritionist. So we don't know, those things don't really easily get reimbursed in the system, and we're looking at bringing those into the community, and we're looking at, for example, other solutions like food pharmacy solutions. We're trying to launch that at Cleveland Clinic based on a Geisinger model and other people doing it. But when you look at the data on that, it was striking. These were food insecure patients who had poorly controlled diabetes with A1Cs over 8. I think they had a couple hundred patients in it. They provided support, coach, nutritionist, education, teach them how to cook, shop, basic things in the community. And the average cost went from $240,000 per patient per year to $48,000, which is $192,000 saving per person, or 80% cost reduction, and all the biomarkers got better and their quality of life improved. Those are the kinds of solutions we need to be thinking of that are more democratized, decentralized, that are outside the box, that are not on the walls of a clinic, and putting people and communities at the center of healthcare, not doctors and hospitals, because we're not going to solve this in the clinic.
So thank you, and we're fortunate to have two technology solutions on this panel. And Josh, I'd like to start with you. And how do physicians or other referral groups know about the kind of work you do? And are referrals a problem? Is the demand there? And what can you say about the growth? And I'll ask you the same question.
Sure. So, and I'll back up to even the question you asked is how do we prevent this epidemic or pandemic? And I completely agree. Community is important. Where we get our food from, what we teach in the school, critical. And I used to run a smoke cessation program for Optum, and we were really successful because everybody in every state is eligible for some degree of smoke cessation program. And so when we could do the same thing with prediabetes, obesity, and diabetes, I think we have a chance. So me, as running a company called On Duo, I may get a contract with an insurance company, or maybe even 2 insurance companies. So then when I try to do a population or public health campaign, I'm trying to find the people that have Anthem insurance in a given state, as opposed to what I could do when I was at Optum, because we had Quit for Life, the smoke cessation program. I could say to everyone, call me, because I'll have a program that you could get paid for your smoke cessation. So until we have true public health campaigns, I think it's going to be really hard. That said, what we do at On Duo, I'm Canadian, and I used to love Wayne Gretzky, and we go with the concept of go where the puck is. So
you don't like him anymore?
I love him. So he moved to LA. So this idea of, hey, prediabetes, amazing. Great, love it, right? Obesity, great, love it. But guess what? There's still 30 million people who have diabetes right now, and that's where the puck is, and I think that's where we can make a difference. And you said something that there's 90 people for every primary care doctor who have obesity. But every primary care doctor might have a panel of 500,000, 1,500 patients. So when they think about what am I going to learn today, where am I going to invest money, where am I going to invest resources, it's not obesity, and it's certainly not diabetes. And so what we're trying to do at On Duo is by creating these virtual clinics, is can we democratize what we consider centers of excellence? So if you actually go see an endocrinologist for diabetes, except for an eye and foot exam, there's not a lot of physical exam. There's not a lot of physical interaction. So the idea is, can we bring that specialty care in terms of remote monitoring, continuous glucose monitoring, expert nutrition advice, expert medical advice, and even endocrinologists through telemedicine? Can we bring that into the primary care doc? So everybody, not just wealthy people who could get access to Joslin Diabetes or Cleveland Clinic, can then get the best care. And we were talking a little bit earlier about this, is we talk a lot about access, and I show this great graph of where our members are and where the endocrinologists are. But what we discovered is social economic status and access is really important, because if you're working 2 jobs, you could literally live next to the Cleveland Clinic. You're not going to take the time to go see the endocrinologist. So how do we make it really easy? And I think that's where Sean and I have this great medium, which is your phone. And we could do a lot of things digitally, so we can potentially get to 30 million people, and not just a small group.
Right. So that's the treatment side, the prevention side.
Yeah, so your question was in two categories on demand and referrals. And both, unfortunately, don't have shortcuts. I think really quickly, so Omata at a high level, think of us as an online program that helps people with obesity-related chronic diseases. We got our start in early risk, so pre-diabetes, and have expanded from there. So what's interesting on demand, per Josh's comment, it's so important to meet people where they are, which in today's world is in front of their screens, and that's especially true in chronic disease. And I think if you could draw a graph of digital relevance and acute disease, chronic diseases are more relevant to digital worlds because you have to intervene on a multiple touch points over a long period of time. So anything chronic needs to be addressed through digital. And that's for a whole host of reasons. And the critical one is, of course, outcomes. Because in order to get outcomes, you have to touch people many, many times longitudinally. And that's great for digital. And that actually helps with the demand side. Because if you make it easier to live with a chronic disease, by making exceptional product experiences that are on your phone, by preventing a visit where you have to schedule time off of work to drive in to get a refill on a med. You're like, why couldn't that have happened in a different way? If you make it simple and elegant, that actually increases your ability to have impact because it pulls on demand. And through tech, you can market in really interesting ways. So, what I always say when we communicate the value of Omata's program is our goal, as from a marketing design team, is to put out something that people feel surprised that it's covered for them. And they're like, well, that's interesting because this looks and feels like the sort of thing that I would have had to pay for. And that can be done in the chronic disease spectrum. So that's on the demand side. On the referral side, it's reimbursement. And there are ways to get enrollments into the program. We partner with IDNs like Kaiser Permanente. We work with many, many plans and employers and figure out, all right, well, where are the contained populations where we know that if we market inside it, we can get people in and get them paid for. And increasingly, our company and others in our space are getting just in-network full contracts where we're reimbursed, where it doesn't really matter where the person comes from. A clinician could recommend it. Because the reality is, if you take a PCP and you approach them and say, hey, look, here's what you're doing today for your pre-diabetics. You're maybe handing them a pamphlet saying lose weight. You're maybe referring to a dietitian, a nutritionist, and then you stop there. We have an amazing program. It's evidence-based. Here's our 12 trials. It's going to be elegant. Your patients are going to love it. If you come in with that message, what you're going to get back is which payers are you covered for? Yeah. Is there access? Mm-hmm. And unless you have a critical tipping point of payer coverage for that doc in their panel, it's not going to happen. You will not be able to influence or move that practice to be able to refer. So you have to get to that point. And you get to that point by skating where you do have coverage, just getting those critical tipping point coverages, and that can kind of catalyze the rest. And this is on a journey. We're all on a journey together here. I think we will get there. I am more optimistic this year than ever before that 5 years out, it will be possible for PCPs to refer into programs like Omata and Onduo. It's just a long road, and it's going to require continued resilience and determination.
Right.
Which you have.
So one of the concerns about all of these programs is the extent to which they're able to address the ethnic and socioeconomic disparities. You began to touch on this, Mark. Yeah. We're not going to have health equity unless those disparities are eliminated. So again, I mean, your communication strategies are probably reaching an elite. My guess is. So how do you broaden that to reach these hard to reach populations who are disproportionately affected?
Yeah, I think we need to do a much better job of having conversations and being in community, and it's time consuming. I mean, I love hearing about the faith-based strategy that you were talking about in Cleveland. This is so compelling. There are really interesting initiatives like this in Houston also, like Dr. Faith Foreman is doing this with Cities Changing Diabetes. I sometimes feel like, and I've visited Geisinger, it is amazing. Shamokin, Pennsylvania, there are 23% of that town has type 2 diabetes, Whoa. I mean, the percentage of people who are under the poverty level, and you go there, and it's time consuming. And I feel like it's really it's sort of fashionable to talk about partnerships and to talk about multi-stakeholder efforts. Like the amount of time and effort and commitment and investment that we need to do. I mean, like, listen to what Esther Dyson is doing. Like, go to her communities. And guess what? They're not all nonstop flights from JFK or from SFO and all of that. And, as a culture, we need to be much more committed, and also looking globally at where are these things happening. The Dietz Foundation worked last year to call 100 people all over the country. Didn't get as many global examples as we had liked, but had a lot of conversations with people and said, Jim Gavin said to us, find out like what is working, what's not working. Phil Gilbert runs design at IBM. He was at this gathering with Esther and Sean and I, a couple years ago. IBM had no idea what was working and not working, and we went and found out this information and put it in. You can see it all. It's free, diatribe.org/anthology. We have little summaries on the way out. But like, what is appealing to these multi-stakeholder groups is a really big deal to figure out. Like patient-centered, all of that, it's fashionable, like we're in the room, but have you actually invested in patients across the whole spectrum? And have you actually figured out what are the different things that so many different sets of patients and their families and their employers need? Because you might not, as Josh says, the number one thing might not be thinking about how to prevent diabetes if you are worried about how you're going to get dinner. And this is going to go into a whole host of questions about policy. Like, we live in a country, we subsidize corn in this country. That is crazy. When we look at what is healthy food, no one even agrees on it. So I'm excited about the opportunities and where it's going, but I think it does need to move beyond, where it is right now, and have Cleveland Clinic, have the Milken Institute, have Big Pharma, all working together.
Well, we'll come back to the policy
ways.
issues,
Okay.
I hope. But so, Sean, you said that your current contracts are with groups like Kaiser Permanente, but can you, to what extent are you enrolling Medicaid or Medicare populations? And are the outcomes in those groups the same or different? And if they're different, which I suspect they are, how do you elevate the success in those groups?
Yeah, so it's a great question. We work with a number of commercial payers on the private side. We actually have 11 Medicaid contracts. There's the CDC effort to put forward these Medicaid demonstrations, and we're the digital provider. I'm thinking like 7 or 9 of them. And what I always say when I start with not just Medicaid, but even seniors too, is you have to answer the question, and sometimes it's asked, like, can seniors use technology? With a response that's, how do you build technology that seniors can use? Because there are many, many UX details, integration details, like all the little things really matter. And it matters in underserved, it matters in seniors. So the first is, can people use it? Like, we deliberately put a cell chip in a scale versus having people pair it with their Wi-Fi or home network or Bluetooth phone, because my mom can't pair a Wi-Fi scale with our network. She's going to call me. So you have to make it simple.
And she do that every day?
Called the Sean's mom test. Like, mom is super like with text messages. She'll write like a whole paragraph and like, love mom, and I'm like, mom, it's like, that's for email. But slight tangent. So you have to make it past the Sean's mom test. Like, first, it has to be easy to use, and then you have to adapt it. So the myth of our underserved populations using technology is bit by bit going away. I think that's something that early on at Omata we got more of, like, oh, my Medicaid patients aren't using tech. I'm like, have you looked at a Pew report? Like, every year over year, increasing mobile adoption in all walks of life. So if you build it to adapt, it can work better. So we have a low literacy curriculum. We have specially trained health coaches. We have special content modules for underserved. We give them special support on onboarding to make sure they understand how to set up the accounts and get kind of going to start, and that's an extra investment. And the outcomes are good. It is
a little bit. Are they comparable?
It's a little bit harder, a little bit, but not to a level where we go to a Medicaid plan director and they're not like, this is amazing.
Terrific.
So, but you have to push, we will continue to work to innovate in that space, because if you are making household 20K a year, you are up against so many headwinds that we could potentially help with, that it feels like there's going to be constant opportunity on the table.
Josh, same question. In a different population, these are people already affected by diabetes. Could you comment on the differential enrollment of, let's say, African American or Mexican American populations and outcomes in those groups, and how, I suspect they're different, how you go about improving the outcomes in those groups?
Yeah, I think, so in full disclosure, we launched in January, and we have various groups who are on our program. We haven't cut it, but specifically by socioeconomic status. But what we do find is it's more a question of reimbursement and what hurdles you have to get through for that. So I think you have a couple progressive Medicare Advantage programs that are reimbursing digital, but on a whole, I think digital is held to a very different standard than traditional medicine because of the fact that it's a new medium. What's interesting, though, and I always think about this, is when I was a practicing physician, nobody ever said to me, what's your quality, and will I give you a contract because you're a high or low quality doctor? They said, okay, you have an MD, I'm going to give you a contract. No, right? Any doctor in this country, in this country could bill for prediabetes education. Sean has 11 studies, 12 studies, and we're still pushing for reimbursement. And so we find right now 40% of our patients or our users are 60 or over, and they get some of the greatest results. So when it comes to these groups, digital is definitely a medium they want. You do have to adapt for some populations. So in a Medicaid population, because data, a lot of people are paying for data. Data becomes an issue when you're using digital programs. But they are people with diabetes, just like anybody else with diabetes. And you have to try to meet them where they're at in terms of, you can't maybe give them a Whole Foods grocery list. You have to the communities they live in, but they have the same needs, they interface with the same mediums, and they get as good, if not better, outcomes than a different population.
Mark, one of the things that is notable about the Cleveland Clinic is that the extent to which it's acted as an anchor institution in Cleveland.
Yeah.
With
the biggest employer.
I know, not only the biggest employer, but they've got a hydroponic garden, they've got a laundry that serves the hospital, they've got a business-to-business venture in the community. That's, to me, an outstanding kind of investment of the hospital and the clinic. Is that how? I don't know how I'm sure familiar with that and probably behind some of it. How can you scale that?
You mean being involved in the community?
Yeah.
I mean, I think that there's a huge effort now to rethink how we connect with the community. There's a new institute that was established in January called Cleveland Clinic Community Care.
You might comment on the clinic or the community that surrounds the clinic.
I mean, it's tough. I mean, it used to not be safe for doctors and nurses and staff to walk outside around the clinic, to leave to go to their car. That's improved, but it's rough neighborhoods. It's neighborhoods you would lock your doors and be scared to go in, and burn out houses. It's pretty rough, and it's a very poor community, and so they really are trying to rethink how we engage with the community. It's tough. I mean, as a nonprofit, it has to invest 5% of its profit into the community, but
that's the community benefit initiative.
Yeah. And I think they're trying to reimagine how to do that, and it's hard because I think there's a lot of feel-good projects, but the question is, how do you rethink care delivery to go beyond the walls of the hospital and clinic? And that's what we're trying to reimagine now, because that's where the solutions, whether it's digital solutions, whether it's community-based solutions. I just was at a session yesterday where there was a report on the, I think, $10 billion that Medicare, the Center for Medicare and Medicaid Innovation Fund is deploying to try to create models of innovation, and the only thing that was effective was community health workers. Or the most effective was community health workers, which was not surprising to me. And I think, I said to the CFO, we need to hire 10,000 community health workers at Cleveland Clinic, and he laughed at me. But I'm like, that's I said, that's where we need to go. Sure. And I feel like you know, it's such a tough problem because, you know, Paul Farmer talks about structural violence. You know, what are the social, economic, and political conditions that drive disease? And then if you focus on the medical side, you're missing all of that. And we have a food system that's driving disease. We have policies, which we'll get into, that are driving disease. We have, you know, targeting of the food industry to poor and minorities deliberately. We've got a number of FOIA requests out that we've gotten documentation of their behavior, which is kind of shocking, and how they, you know, they fund the NAACP, they fund Hispanic Federation, they fund hunger groups, and I think they're trying to control the changes in policy, whether it's taxation, and the changing those issues that are driving disease structurally in our society have to be done, because this is our biggest problem. You know, we talk about all kinds of issues, but this discourse is really absent in the political conversation, which is shocking to me, because when you look at the numbers and the costs and the productivity losses and the competitive losses and the national security issues and the climate change, the environmental issues, the challenge of kids learning, and even linked to poverty and violence. You know, you look at studies in prisons where they give violent prisoners healthy diet, reducing violent crime in prisons by 56%. They had a multivitamin reduced by 80%. So what are the implications for that of keeping these communities poor in this vicious cycle? So we have to address that. And I think Cleveland Clinic is really taking steps to do that. But it's tough to reframe the concept of what the role of a healthcare system does. And it's not just episodic care. It's really changing. And the change in ACA and the accountable care and value-based reimbursements will start to shift that, but they don't know what they're doing.
No, right. It's the transition from sick care to health care.
Yeah, and it's challenging because doctors are still in their model of treatment of disease and episodic care. They don't know how to think about, gee, maybe we need to build community models, and we need to hire 10,000 health coaches and teach people to cook and shop and build communities and groups, and
Right.
Oh, could I just ask a question? I mean, I'd love to know, what is the Cleveland Clinic's appetite for working with philanthropists? You know, you have so many amazingly committed people in Cleveland. I mean, we're in the Bay Area. It is crazy, the amount of wealth creation and the amount of inequity. And I don't know if you think that's what you're good at as the Cleveland Clinic, but I would really urge you to think more about that. Yeah.
Well, please,
I mean,
bring it on.
Well,
my email is hymanm@ccf.org. Just send the checks.
But I mean, I kind of had the impression that you said 10,000 healthcare, community workers, kind of jokingly, like, that will never happen.
Yeah.
But I mean, the amount that we are investing or spending, I mean, the most costly 1% of people with diabetes in the United States, it's $100,000 a year times 200,000 people. That's $20 billion. The upper 1/10 of 1%, and you have many of them. Sorry, I mean, but you do in Cleveland. That is $1 million a year times 20,000. That's another 20 billion. Can't we take that and invest that in what Sean is doing and what Josh is doing and what Verda is doing, and what your CEO, I guess, doesn't want to think about is hiring 10,000 community healthcare workers. Like, why do we think that's the only thing that's effective? Because we can communicate with them as patients. It's an investment, not a cost. So I think him working with some philanthropists and you urging that would be incredible for patient communities.
We are.
Especially the patient communities that you're talking about, Bill.
No, we have a proposal for the food pharmacy, which is 2-year study, rigorously collecting data and doing this intervention.
And just on that, like, making sure you're learning from Geisinger and you're learning from Zuckerberg General. There are some places that have done it. So anyway, I love hearing that. Sorry to get too excited about philanthropists.
Really quick, just a really quick comment to follow up on that. So I'll just take a chance to put in a plug for other Milken Institute research by Marlon Graff, who's here in the room, and another colleague of ours. And so it shows on community health workers that the increased ratio of community health workers to the population, if you compare across states, is very significantly associated with better health outcomes and access to care, increased life expectancy in particular.
Absolutely.
So anyway, that's available on our website as well. But and they've looked also at other evidence of the effectiveness of.
But we have a reimbursement problem. We don't really have evidence-based medicine. We have reimbursement-based medicine. That's the problem.
Exactly. That's the issue.
Yeah. To be clear, though, I don't think it's for a lack of understanding. It's not for a lack of efforts. I think it's a lack of reimbursement and a lack of basically publicity and awareness. So my guess is almost every single person who has insurance has some program available to them for prediabetes or weight loss, but nobody knows about it because that's not what the health plans are promoting, and it's not because because we don't have public awareness. The science is there, right? We understand a lot of the biology. We understand some of the physiology. We're getting a lot better on the pharmacology, but still it's access and it's getting paid for that.
Right.
Agreed.
So let's, I want to move on to policy, but start with payment policies related to your two programs. And I think I still have this right, that the CDC has provided certification to providers in the DPP in a community-based program, but not not a digital program. Is that correct?
That's correct.
Okay, and CMS likewise will pay for that. Will pay for a provider, but also not for a digital program. Is that also true? So where do we need to intervene for that? Is that at the level of? I mean, having been at the CDC, I know how potentially complicated that is, but I'd be interested in where you think that change has to occur, because if you're going to open up a scalable solution, how do you pay for it?
It will be a mental model shift and paradigm shift. I think when tech entrepreneurs come into Omata and they're thinking about a digital health offering or company, what I always remind them is like, look, digital health is still the underdog. And there's no shortcuts here. Like, I think you just have to have a commitment to research, publish evidence, just continue to and bit by bit, you'll kind of shift and point the world to a different place. And that's what we've been doing as it relates to this Medicare benefit. I mean, Omata's put forward and invested in a year-long clinical trial in Medicare Advantage patients that we've published with amazing outcomes. We just published a paper comparing us that the VA ran against brick and mortar programs to try to show equivalence, that look, this is delivering the same outcome that you might care about or you've associated value with, but at scale. We are the first to say, don't even pay us if it doesn't work. On our commercial contracts, we charge on % weight loss outcomes. So we don't make profit unless we're getting to people for outcomes that matter. And we hope if we just continue to say that and say that and say that and say that, and don't let off the gas there, we will get there in time, because it needs to happen. And it needs to happen particularly in the Medicare diabetes prevention benefit, because right now that is shaped to just in-person programs. In the spirit of what I said first, digital matters a lot when you're talking about long-term engagement and longitudinal touch points. And there is savings to be left on the table. There's enormous health impact to be left on the table. And I think as we start to count and look at the metrics behind the Medicare diabetes prevention benefit, we will see that in order to really fulfill the promise and dream, digital needs to be part of the solution. But it's a constant dialogue.
So I assume that you and Josh are in constant discussions with CMS. Is that right, Josh? Is it the same problem?
No, it's the exact same problem. But I think there's actually one level of detail, though, that I think is really important, and it's a question of selection and selection bias. So one of the challenges that CMS puts forward, and I think this is really valid, is if you're a digital program and you market digitally and you go through you're on Google, you're trying to find them on Facebook, you get a natural selection of the people that sign up. I think there is a role for the referral patterns, whether it's coming through the Geisinger's or the physician's office, where they'll help select people that actually truly need the program, as opposed to people that want the program. And we make ourselves available to the want, but we also have to figure out how to get to the need. And one of the questions that we hear from government is it's not really a question of effectiveness, but it's of are you getting it to the right people? And one of the things that is relatively reasonable through the primary care to the specialty network is they'll only refer, technically, the people who truly, truly need a specialist. One of the challenges that I put on my company is, and I saw this when I ran benefits for Target, I saw it when I ran wellness for Optum, is 5 to 7% of people will do whatever you offer them. And what Sean and I have to do is prove that we're not just getting the 5 or 10% that are going to raise their hand and do it, but we're getting the 10 or 15% that truly, really need it. And so when it comes to CMS, at least what I'm hearing is it's not just a question of is it effective, but are you getting it onto the right people? Which is it.
So let's go to this broader question of how do we, what are the kind of innovative or scalable programs that will take care of the progression of prediabetes to diabetes, or even mitigate diabetes in those who have it? What are the policy solutions that, and I think we're now talking about population-wide. Mark, you began this, and then we'll turn to Kelly.
I mean, I think it's a complex issue and there's multiple solutions, but I think the concern I have is we have to have the right solution, and the science has to match what we're offering people to get people better. And I know Sean and I talked at the very beginning of this company, they were using the DPP trial and the diet related there because it was proven in evidence, but it also was based on old, outdated research on nutrition, which was saying that low-fat diet was the diet that would fix it. We know that's not true anymore. Virta Health, for example, is a scalable platform that's used coaching and support for very sick, overweight diabetic patients using a ketogenic diet, and has 60% of the diabetes reversed in a year. They have 2-year data, which is showing consistent outcomes. They had 100% off oral hypoglycemics, 94% reduced or off insulin, an average of 12% weight loss, which is outstanding. And so we have to get really the IP right of what to do to change biology. But then we have to look at
So is that scalable?
Yeah, this is a scalable digital solution.
Oh, digital.
It's a digital solution. Okay. So they have multiple touch points with the coach. They get all their biometrics. They measure the ketones. And they have 83% adherence at a year measured by ketones that are digitally transmitted. So there's solutions that I think are digital, that are scalable, and that are able to be reaching a lot of people, that should be reimbursed. That's a key policy change. But I think the bigger policy change is, what is the environment that we can influence by changing the food policy in this country? And I think, I was just in Abu Dhabi, and the head of the Mubadala Fund, which is the sovereign wealth fund, basically said they put in a 50% soda tax and 100% energy drink tax. And they had a 50% reduction in soda consumption, a 70% reduction in energy drink tax. That's just one idea, but there are many things looking at, like you said, stop subsidizing commodities, subsidize specialty crops, which are 1% of our subsidies, which is fruits and vegetables, and taxation issues, looking at food marketing to kids. I think it's a huge issue. We've got massive marketing, and in Chile, they actually found that by ending marketing to kids, they dramatically reduced consumption and food patterns.
Well, they didn't actually change marketing to kids. They changed the logos. So Tony the Tiger no longer supports Frosted Flakes.
Right. Tony Tiger's dead. Right. Yeah. But they did eliminate any advertising directed at kids from between 6 in the morning and 10 at night. And so you see, there are scalable policies that can be done, but the political will for that is really tough. And
right.
There's so many opposition forces in the food industry that makes it really challenging. I realize some of those companies may be in the room, but that's a huge challenge, and we have to rethink our food system. And I think big food companies are doing that. Pepsi's doing it, Nestle's doing it, Mars doing it. Create a new sustainable coalition for rethinking food. It's fascinating to see how the consumer demand is actually driving their behavior. But those have to change. So we have to reimburse the right things, and we have to actually change the food environment through multiple strategies.
Policy strategies.
Right. Yeah.
So, Kelly?
Yeah, this is so interesting. I loved what you were saying before about just the carbogenic environment, because there is a lot that could happen on policy. And also, I think there's a lot that can happen with employers, and there's a lot, even like Aetna, the former CEO of Aetna, Mark Bertolini, many of us probably know him as really a hero. He's coming out with a new book, April 9th, talking about his like mission-driven leadership and about how the employees want this, where he works. And I do think as it's Gen Z now that we're hiring coming right out of college. I think they're demanding it. It's not, it's full employment in San Francisco, New York, Boston, et cetera, but it's maybe not be full employment everywhere, but they are demanding this. And so I think not only looking to what can happen on the policy level, but looking to employers and citizens to drive the policy, to have citizens asking for. I think a lot of citizens have no idea that we're subsidizing corn. They have no idea that it is so hard to get to patients, all of that. So that's my favorite policy idea. What is your favorite policy idea? Eliminate the subsidy and also prompt subsidies in fruits and vegetables. And I know it's complicated. It's not as simple as it sounds, but it must be possible to have people eat healthier. And also look at CVS. They got rid of all tobacco. That was $2 billion off the top line. Maybe they're not going to get rid of all junk food, all soda, but if we look at SNAP, what is the single, biggest use of SNAP dollars? It's soda.
Yeah, Cleveland Clinic got rid of all sugar-sweetened beverages.
So,
right. So hospitals
some of those. But what do you?
Have led on this.
Yeah, but I'd love to know what you would love to see on policy.
Well, I'm happy to share that, but I'm just as interested in what the rest of the panel will say. I mean, because you two guys are in the technology space, but surely you think outside of that, or think about how to expand technologic solutions to the entire population. I'd be interested in hearing your thoughts.
I mean, our mindset, and a bit of my mindset has been, all right, we need to create an environment where people have a group setting, a coach. Like, we almost need to create a little shell around them to protect them from all the horrible influences out there in the world. Like, it's like, I would love for me to personally feel like actually it's helpful. Like the environment, the climate, the food policy, the food climate we all live in is actually an additive to our program, because right now it's not an additive to the program. That would be an amazing world to get to, and I think would further our outcomes and ability to have impact. And I think it can happen. And the other, like, one just interesting thing on demand. So I was a couple of months ago sitting down with the CEO of a very large Japanese beverage company, and what he was sharing is like, look, we're really interested in healthy drinks, and this is because as the population has aged, there's more anxiety and worries about Alzheimer's, cognitive decline, and that is becoming viewed as associated with sugar sweetened beverages. And they're feeling a huge pull to launch health-forward drinks. And I'm like, that's a beautiful thing to hear. So it's and I think it'll be a little bit of a push-pull that can get us there.
Yeah. Josh?
Yeah, I agree with everyone, but I think this focus on food is a little bit misguided, because there's a lot of people who are overweight, even obese, who are metabolically healthy because they're exercising, and there are quite a few.
There are.
But so sure, we could transform food in the country, which would be great, but I'd rather see transform physical fitness and movement. Kids don't play anymore. You don't see kids out on the weekends. There's schools that cancel gym. And I'm not talking running marathons, I'm talking moving. And yes, I'd love to see food reform, but more importantly, I'd love to see exercise.
Well, President Obama said that every kid should be exercising 60 minutes a day, 6 days a week. So some of the encouragement happened, but like...
Right. But so I think, Josh, I think you're correct that there have been just as substantial declines in the calories spent on physical activity as there have been on the increase in the calories spent on food. And I think that there's been a disproportionate emphasis on food.
Absolutely.
Certainly if you're...
Not by the food industry, they focus on exercise.
But if you're talking about prevention, there's an equal case to be made for physical activity and diet.
Yeah,
if you're talking about treatment, physical activity reduces comorbidities, but doesn't help people lose weight.
And the reality is you have to run 4 miles to burn off 1 soda. You have to run 4 miles every day for a week to burn off 1 supersized meal. You can't outrun a bad diet.
Absolutely, totally agree with that. So food is one aspect of it, but the problem with it, even the way we're talking about it, it's so paternalistic. Let's just not make sodas available to people. Well, there is human choice in this, and there is human behavior, and there are people who will pay the $12 a soda because there's still people who smoke. But I do think that the single-pronged approach of let's just address food, it's not going to solve it. What we saw with tobacco industry was actually really good. Massive public awareness campaigns, taxation, free smoke cessation programs, education in the school systems, and trying to prevent people from starting. Like, there is no silver bullet in this. And to say, oh, it's food taxes, well, no,
it's multiple.
That's one.
So we have 3 minutes left. And I'd like to hear from each of you one sentence about the highest priority. The sentence can go on for a while, but there are a lot of commas and colons and stuff. But Hugh, the most important thing.
Yeah, I was going to say, can I put a lot of commas in there, and then before I get to the final period?
Right away.
So for me, all of what has been said here is incredibly valid, but it is a multi-sectoral approach involving many different parts of society. I mean, we haven't had a chance to touch on some of the interventions that could be done in schools to reduce the childhood obesity epidemic. They're building infrastructure, bike paths, encouraging. I mean, there's so many different ways to get at this.
I think there was a period there. Thank you.
I think this is bottom line is we need to think of multiple things.
Oh man, this is one. Okay, I'm gonna actually try to do this. All right, one sentence. All right, so let me think. If the acceleration of reimbursement coverage on the commercial side was mirrored by commercial reimbursement on the private side, and Omata ended up in a world where we were covered by all, I can all but promise you we would find a way, because it would be sustaining for the company to get people in the door from multiple referral sites with plenty of demand to reduce incidence of obesity-related chronic diseases, period.
Cool, yeah, good.
The run-on sentence.
Hey,
Kelly?
That's good. Speaking in paragraphs is hard, but these guys have done a good job. I think listening to patients and caregivers and families about what they need, recognizing that these are progressive conditions. Prediabetes is progressive. Type 2 diabetes is progressive. Looking at it from a multi-stakeholder perspective and encouraging investment on therapy, cardioprotective, renal protective, encouraging therapy on what's easy to use, making the healthy choice the easy choice, and encouraging investment and listening more to you. And I hope you're going to give us a paragraph too.
Okay, I'll be short. I think the key things that could really move the needle are changing reimbursement for food as medicine and for community-based solutions like these guys are doing, or other kinds of community-based solutions. I think those are the biggest levers to change behavior, which is changing the money flow.
Perfect.
I'd say universal access and coverage, because once you could do that, you really can do population health. When it's still just for a narrow population, you can't solve the problem for the country.
Right. So Kelly's been pushing me on a concluding comment, and I think that these type of massive problems are not going to be solved at the federal level. Not in they certainly, even with the Obama administration's massive push on this, we made progress, but we didn't solve the problem. Maybe you could argue that we did reduce obesity in 2 to 5-year-olds as a result of the changes in the WIC package. We flattened the prevalence in 6 to 11-year-olds. But I think that if social change around these issues is going to occur, it's going to begin at the community or the state level, not at the federal level. And that it's going to take, as I think you pointed out, Kelly, a cross-sectoral initiative. And how one achieves that through a focus on obesity, I'm not sure that is the focus. I think it's still, people still view that as a cosmetic problem rather than a medical problem. And whereas diabetes may be a much more cogent area for engagement. So join me in thanking this panel. It's been a great discussion.